Hello students, welcome. Myself Dr. Roshini, your OBGYN faculty at DigiNerve. Yes, our INICT exam is close by and everybody is preparing for that. So we want to bring you some MCQ discussion, especially the important and high yield topics. So let us do some few high yield topics, quick revision of MCQs. So to begin with the first question, so let us begin our first question. That is, a 26-year-old primea gravida at 7 weeks of gestation presents for first antenatal visit. Okay, this is a first antenatal visit. By manual examination, clinician notes that uterine body and cervix appear to be two distinct entities. Okay, so there is uterus and cervix, two distinct entities, notably softening of the intervening region. Which of the following is correctly identifying the sign? So what is the sign? Where there is a softening of the uterus and then you can see the bulk of the fetus inside. So what is that sign called as? It is Hegar sign, isn't it? So Hegar sign, due to softening of the uterine isthmus, useful in early pregnancy detection. Yes, that is a clear-cut sign of a Hegar sign. So what are the different signs of and first trimester examination? Yes, Chadwick sign. Here you can see the bluish discoloration of the cervix and vagina. So C. Okay, you can remember like that. Blue discoloration of the vagina and cervix seen as Chadwick sign. Okay, it is seen from 6 weeks. It is observed on per speculum examination and not by manual examination. In ours, they are given as by manual examination, isn't it? So Goodell sign is softening of the cervix. Cervix is usually firm, but in pregnancy it becomes soft, like that of a ear lobule, isn't it? So that is your Goodell sign. Hegar sign, as shown in this, softening of the isthmus. You can feel the bulk of the uterus and the fetus inside. Okay, that is your softening of the isthmus seen on bimanual examination. Pama sign is the uterine contractility. So every some minutes there is a contraction. Initially, in the initial part of pregnancy, in 10 minutes you can feel almost, in 2 minutes only you can feel two contraction, but later as it progresses the contraction frequency reduces. So this is ideally done before 10 weeks, not after that. That is your PAMA sign. The uterine contractility felt manually. Okay. Coming to the next question, a 34-year-old multi-gravida woman, gravida for para 3, at 31 weeks of gestation, presents with recurrent painless vaginal bleeding. Her previous deliveries were all by cesarean section, and on examination, she is stable and fetal heart sounds are normal. Okay, so painless vaginal bleeding means what strikes to your mind first? It is a case of, yes, it is a case of placenta previa, correct. So here in placenta previa, the fetal heart rate is normal as of now. Transabdominal ultrasound reveals anterior placenta completely covering the internal os. Okay, so now you know it is a case of placenta previa. Which of the following complication is highest risk for her? Okay, case of previous LSES with placenta previa. With every cesarean section, the risk of placenta previa increases, and as the risk of placenta previa increases, risk of placenta accreta syndrome increases. So in normally in every from 3% it becomes to 40% in a case of previous 3 LSES. Okay, so risk of placenta accreta syndrome increases to 40% if there is 2 or more cesarean section. Okay, so that is why the most or high risk factor for this will be your placenta accreta syndrome. Vasa previa for everybody with placenta previa or low lying membranes, the vessels running in the membranes. Okay, so that is called your vasa previa. Here the fetal loss or the blood loss will be only fetal loss. So fetal blood loss is there. Okay, so here the fetal heart rate is usually not normal. In vasa previa, it is 100% fetal blood loss. There is definitely bradycardia in that patient. Uterine rupture, in a case of previous LSES it is there, but since it is all mentioned about placenta here, so accreta syndrome is more important. Placental abruption. So what is the highest for placental abruption? Yes, you can see here abruption, hypertension and trauma. Okay, these are the high risk factors for your abruption. polyhydramnios, sudden rupture of membranes. There's also a type of trauma, sudden decompression of the uterus. Okay, or in case of road traffic accident history they have given, then you should think in abruption. So also in abruptio placenta, antepartum hemorrhage is a painful bleeding, whereas in placenta previa, antepartum hemorrhage is a painless bleeding. Okay, accreta is the most severe or high risk factor for a previous LSES with placenta previa, which you should always rule out in a case of a placenta previa and previous LSES. Going ahead with the next question, a 24-year-old woman presents with lower abdominal pain, fever, abnormal vaginal discharge. Okay, so lower abdominal pain, fever, and abnormal vaginal discharge. All these categories fit into that of a PID, isn't it? CDC criteria. I know you've all read that. Please revise. That is very important for your exam, the CDC criteria. Pelvic examination reveals cervical motion tenderness. Okay, another classical feature of PID. What are the two places where you have cervical motion tenderness? One is PID, the other is ectopic pregnancy. Correct. Adnexal tenderness. She is sexually active with multiple sexual partners. One of the commonest risk factor for PID is multiple sexual partners and does not use barrier contraception. Again, she is becoming a high risk factor because of not using condoms. Which of the following organism is most commonly associated with the initial infection leading to PID? So which of them, which are the two commonest organism? One is your Chlamydia trichomatis, another is your Neisseria gonorrhea. So these are the two important or commonest organism causing your PID. Mostly it is polymicrobial. Okay, if there is an option of polymicrobial, definitely go for that. If there is specifically, it is mostly Chlamydia or your Neisseria. Okay, these are the two common organisms. E. coli is a commensals, normally they're everywhere, and Mycobacterium tuberculosis is usually slow growing and it is seen later stages. Genital TB usually have menstrual complaints, pain abdomen in the later stages, not in the initial stages. No cervical motion tenderness here. And Streptococcus, as we told, polymicrobial, it can be there, but as such not specific for PID. Specific is your Chlamydia and your Neisseria. Next, coming to the 27-year-old woman seeks non-hormonal contraceptives. Okay, so non-hormonal contraceptive method due to history of migraine and aura. So here, medical eligibility criteria, your MEC criteria of UK, medical eligibility criteria. Please read this. It is very important for your exam, especially for whom you can give the hormonal, for whom you, which hormonal method is best is what is given. The four categories are there: low risk, moderate risk, and high risk. So in these patients for whom to not to give OC pills is what you should know. Especially history of migraine with aura, OC pills are contraindicated. You cannot give for them. Okay. She is considering use of fix. What is this? This is a spermicidal, not a spermicidal. There are two kind of things. One immobilizing the sperm, one other is spermicidal. So fix is your immobilization of the sperms. Okay. This is prevents mobility of the sperm because of increasing acidic pH. Which of the following best describes its mechanism of action? Okay, that is what they have asked. So it increases the pH. Usually sperms require a alkaline medium, but very high acidic medium will reduce its mobility or cause its immobilization of the sperms. It will not move. Okay, that making it immobilized and cannot reach the ovum. So this makes a this is how it helps in contraception. Okay, so well, let us see. Inhibition of ovulation. So non-hormonal cannot inhibit ovulation. Only hormonal methods will inhibit ovulation. Okay, so this cannot be the answer. Sperm immobilization by altering vaginal pH. Yes, this is the answer. Okay, it is not a spermicidal. Your normal, the diaphragms or the spermicidal gels are different from this. Formation of a mechanical barrier over the cervical os. So this is your diaphragm. Mechanical barrier. It is called diaphragm over the cervical os. So cervical diaphragms. Thickening of cervical mucus preventing sperm penetration. So this is mostly done by who makes the thickening of cervical mucus? It is progesterone only pills. Your progesterone only pills helps in thickening of the cervical mucus and prevents sperm penetration. Okay. So finally the answer will be B. So the chart maintains acidic pH inhibits sperm mobility. Okay, so it less than 1 hour before intercourse you should use this. Copper IUCDs, again they are spermicidal because of it is a sterile medium causing spermicidal. Okay, spermotoxic via copper ions. Condoms are physical barriers. Diaphragm and spermicides are barrier methods which you use in cervical diaphragms or even condoms. Coming to the next question, Rh negative women is 32 weeks of gestation with anti-D antibodies level of 1 is to 8. Okay. So, what is the finding of MCA Doppler most suggestive of fetal anemia? So, once you're in an Rh negative, how do you follow up? First, you keep doing ICT. So, once ICT comes positive, you go for titers. So, if it is crossing the critical value, then you will, that is more than 1 is to 16, then you will go with the MCA middle cellulatory PSV. Okay, middle cellulatory PSV is the peak systolic volume. If it is more than 1.5 multiples of median, then it is suggestive of fetal anemia. Okay, so here more than 1.5, this is the value. So the middle cerebral artery PSV, if it is more than 1.5 multiples of median, that means there is already set in fetal anemia. You can either do termination if it is term, or intrauterine transfusion will be the option. Okay, intrauterine transfusion, or if it is preterm baby, 28 weeks, 30 weeks, 32 weeks, intrauterine transfusion. And if it is more than 34 weeks and term baby, then you can terminate and give post delivery transfusion. Okay, and also remember, in case of middle cerebral artery Doppler, if there is increased diastolic flow, okay, in the systole also there is more diastolic flow is maximum, that says it as brain sparing effect. Already the brain has got affected. If normally we want diastolic flow also, isn't it? In diastole also there is some amount of flow that is in your uterine artery. Uterine artery diastole should have a flow, it should not reduce. But in brains, that is in your middle cerebral artery, if there is an increased diastolic flow, that means it is a case of brain sparing effect. So going ahead with the next question, a 30-year-old woman with two prior second trimester pregnancy losses. Okay, two second trimester losses, presents for evaluation. Both losses occurred around 18 to 20 weeks. Okay, mid trimester. Okay, second trimester. Each proceeded with a sudden painless expulsion of the fetus. So what is this? Painless expulsion of the fetus abortion. What is this? A case of? Yes, a case of cervical incompetence, isn't it? So the cervix is not enough strong to hold the fetus. That is why its cervix is dilating as the fetus grows, and there is expulsion by around 18 to 20 weeks without prior uterine contraction. She is currently asymptomatic and is not pregnant. Remember, she is not pregnant. Which of the following investigation finds during interconception period would be most diagnostic of cervical incompetence? Okay, remember, there are two investigations in cervical incompetence. One during pregnancy, one interval period when she is not pregnant. So when she is not pregnant, what are the two important things that we can do? Yes, we can do HSG, or we can do is a Hegar's dilators test. So what is an Hegar's dilator? When you put a number 7 Hegar, if it goes easily inside, that means cervical os is not strong. Or when you're removing, there should be a snap sound. If there is no snap feel that you can get out, the cervical os should close once you remove. If you cannot feel that, that means she is having cervical incompetence. And in case of HSG, you can see the funneling of the cervix, especially if you do it in the just premenstrual. Because of progesterone effect, you can see some amount of funneling. So because of that reason, during intermenstrual period, we usually take the Hegar's test and not the HSG. And coming to during pregnancy, what all things that we can do? We can do the cervical os measurement from first trimester. If any of the measurement is less than 2.5 centimeters, then consider your cervical encirclage, elective cervical encirclage. Or you can see funneling. You can see usually cervix should be T-shaped. Here you can see Y-shaped or U-shaped. So initially it will be Y progressing to U and then finally expulsion of the fetus. Okay. So internal os dilates during the hysterography and in a proliferative phase. So in a proliferative phase, we usually do not prefer doing because of progesterone effect. Cervical length of 2.5 centimeters on transvaginal ultrasound. This is usually done in pregnant. Since our pregnant patient is not pregnant, so these two options don't go. Passage of a Hegar's dilator number 7 beyond the internal os without resistance in the Premenstrual phase. Yes, this is the correct answer. So without resistance, either it goes, or when you remove out, there is no snap sound. That means there is cervical incompetence. V-shaped funneling of cervix on ultrasound in early pregnancy. So she's not pregnant. Again, this is not the answer. So correct answer is C. Going ahead with the next question. 18-year-old woman presents with lower abdominal pain and her bleeding per vaginum for past 2 days. Okay, pain abdomen and bleeding PV. Her last menstrual period was 6 weeks ago. On examination, she is pale and hypotensive. Tachycardia is there of 116 beats per minute and has a marked cervical motion tenderness. Urine pregnancy test is positive. So she is having cervical motion tenderness, hypotension, she is pale. Everything is a classical feature of cervical motion only. I told you when we did our PID, isn't it? So what is this? Is a case of ectopic pregnancy. Okay. Transvaginal ultrasound reveals empty uterus. So again, there is no intrauterine sac. Free fluid in the pouch of Douglas and paracolic gutters. What is the most likely diagnosis? Is it a threatened abortion? No, there is nothing intrauterine, so it cannot be a threatened abortion. So this is a wrong answer. Ruptured hemorrhagic corpus luteum. So corpus luteum would not give you a positive pregnancy test, isn't it? So everybody, there is a corpus luteum. Once it ruptures, do we all have a pregnancy positive? No. So this is also wrong answer. Ruptured ectopic pregnancy. Yes, this is the correct answer. Incomplete abortion. Again, we don't have anything intrauterine, so this is not an abortion at all. This is a case of ectopic pregnancy. Okay. So the correct answer is C. So thank you for listening. So this is all your high yield topics MCQs. I hope you are preparing well. All the best for your exams. Thank you.